Okay, now this is a busy slide, and I know there's a lot on here, and usually I don't include this much in a slide, but the reason we did it this time is because I want you to be able to compare all of these things in one place so it's easy. Okay, so the first thing I want to say is a lot of these, the epidural hematoma, the subdural, and the subarachnoid hemorrhage will tend to present with increases in intracranial pressure. So let's just quickly review some things we might see with increases in intracranial pressure. We might see papilledema, for example. We might see a Cushing reflex. What is a Cushing reflex? So remember, the Cushing reflex is made up of 3 components. Okay, the first one is hypertension. And, part of the way that I remember that is I remember that the cerebral perfusion pressure, the pressure that perfuses the brain, is equal to the mean arterial pressure minus the intracranial pressure. Now, if I increase the intracranial pressure, right, my cerebral perfusion pressure is going to go down. So the way to compensate for that is increasing the MAP. So that's why these patients will be hypertensive in the setting of increased intracranial pressure. The hypertension may cause these patients to have a reflex bradycardia. Okay, potentially. Now, this is how I remember it. I'm not telling you that this is the complete physiology behind the Cushing reflex. This is just how I, go about remembering this thing. Okay, so you might have some bradycardia. And the other thing that tends to happen, especially when you have really high levels of intracranial pressure, you tend to have irregular respirations. Okay, so the classic one is the Cheyenne-Stokes respirations, which are basically where the patient will have irregular breathing or alternating periods of deep breathing in some cases, and then they'll have these periods where they're not breathing at all, periods of apnea. Okay, so hypertension, bradycardia, irregular respirations are very classic for the Cushing reflex, so that's something to look for. That might be a sign of increased intracranial pressure. Then we have headache on here. This is very classic. The lateral rectus palsy, cranial nerve 6 tends to be affected very early. We may have ipsilateral mydriasis. Again, you can have anisocoria. An ipsilateral dilated pupil is also a sign potentially of increases in intracranial pressure because the parasympathetic fibers, again, are going to be affected first on cranial nerve 3. You might see altered mental status, confusion, nausea, vomiting, etc. But these are the big signs to remember. Before we go any further, like we said with stroke, head imaging post-trauma, CT scan without contrast. Usually you're going to scan the cervical spine as well. You might have them in a spinal collar. But in board questions for step 1, again, any kind of trauma or concern for stroke, get a head CT without contrast. Okay, that's a good first step because you're looking for hemorrhage of some sort or hematoma. Now, epidural hematomas do not cross suture lines. Okay, subdural hematomas do cross suture lines. Okay, so that's one. So this is one thing to kind of keep track of. Again, you're going to have to compare these 3 because in board questions you have to juxtapose these 3 and then a couple different other pathologies. Okay, but these are the big 3. So now when we're talking about what's causing the lesion, epidural hematoma, everybody knows it's the middle meningeal artery. It's okay if you don't know, but that's the big thing. That's the high yield point. But then board questions, tend to get harder over time. So then they start asking about, well, what branch does it come from? It comes from the maxillary artery. Where does the maxillary artery come from? This comes from the external carotid artery. Okay, so the board questions, like I said, over time, they have a tendency to get harder. So, just giving you the full information here because I've seen board questions go as far back as to ask about the external carotid artery. Okay, so just know the branches of this artery. It's very high yield. And, usually this is going to occur because of some trauma at the terion. So the terion is the location where the parietal bone, the temporal bone, the sphenoid bone, and the frontal bone all come together, and it tends to be a site where the middle meningeal artery can be damaged very easily. Okay, so fractures there or in the temporal bone in general tend to precipitate this type of pathology. Okay, so this is very high yield. The way that it presents, the patients, they'll have loss of consciousness because of the initial injury. Then they'll have this lucid interval where they're going to regain consciousness. Okay, so the hematoma at this point is expanding. It's getting larger, but it's not large enough to cause symptoms. So eventually the hematoma gets really large and we see this elevated intracranial pressure. We might see some of these findings, and then the patient will start to go into a coma or lose consciousness again as the intracranial pressure gets higher, because remember, this is an artery. This is an arterial bleed. It's bleeding very briskly. Okay, so it can lead to very significant levels of intracranial pressure and then eventually promote an uncal herniation because there's so much pressure they're pushing, it's going to push everything downward. Okay, and so this is where you can get this ipsilateral dilated pupil or ipsilateral rectus palsy. Again, classic findings for elevated intracranial pressure. And this is particularly high yield to remember the finding you see here. It's going to be this biconvex hematoma. It's lens shaped. So if you go back to your lenses from physics, okay, so kind of a lens shape, you might see some midline shift away from the side of the lesion. Very classic for an epidural hematoma. Now, how does that compare to the subdural hematoma? Again, remember, the subdural hematoma can cross suture lines. Epidural hematomas do not. Okay, and that subdural hematoma tends to be from the bridging cortical veins, so tearing of these veins. Now, the first thing I want to call your attention to, in epidural hematomas, we're talking about artery. Here we're talking about veins. So the bleed might not be as brisk, potentially. Okay, now this is going to be the area between the dura and the arachnoid. So it's one layer deeper than the epidural hematoma. There's different types of subdural hematomas. There's acute, there's chronic. Now, if it's acute, it tends to be a presentation where the patient has a profound depression in their mental status very quickly, whereas chronic, it might be, okay, the patient's been a little bit more confused than usual over the last few weeks, and it's progressively worsening. Now, if it's an acute bleed, okay, on a CT, usually it's going to be hyperdense, like you see with the epidural hematoma. It's going to be very bright. So this would most likely be an acute bleed here as well. So when it's brighter, it tends to be more of an acute bleed. If it's a darker, more hypodense meaning usually darker than the surrounding tissue, that tends to be more of a chronic bleed. So just keep that in mind. Okay, and again, these tend to be lower pressure bleeds altogether, but that doesn't mean that they're not necessarily, significant or emergent in some cases. Now, the classic patients, when they ask about this, there's going to be elderly patients. That's number one. That's the highest yield. So it's going to be an elderly patient that recently had a fall. These elderly patients, they have cerebral atrophy, and this tends to predispose them to tearing of the bridging veins. But the other things that you want to look for is shaken baby syndrome, a child with some form of child abuse. Maybe they have retinal hemorrhages. Okay, so a subdural hematoma would be classic in those patients as well. And then I'd say for like third and fourth high yield would be like someone in a motor vehicle accident or some blunt head trauma, or then a patient that is, is consuming a lot of alcohol. You might see subdural hematomas there as well. And these present as a crescent hematoma. So as opposed to the lens shape, this is going to be more of a crescent. Okay, you can see there's definitely midline shift here on this in this version. This signifying that there's some elevated, increased intracranial pressure. Okay, finally, we have the subarachnoid hemorrhage. Okay, so the subarachnoid hemorrhage is going to be due to a rupture of a berry aneurysm, most likely, or an arteriovenous malformation. But the high-yield one is definitely going to be these saccular aneurysms. And again, now we're going one level deeper. Now we're in the area between the arachnoid and the pia mater. This is classically going to present as the worst headache of the patient's life. That's how this tends to come up. It's going to be a 10 out of 10 headache, thunderclap headache, and they're going to have meningeal signs. They might have a positive Kernig or Brzezinski sign, and you might be thinking, oh, this looks like meningitis, but they might not have a fever, for example, or a lot of the significant risk factors that go with that presentation. For example, it might be a patient that has meningeal signs, but then has a history of autosomal dominant polycystic kidney disease, which we'll talk about in a minute, which, because autosomal dominant polycystic kidney disease would predispose this patient to having a berry aneurysm. Okay, so these patients, again, mental status could progressively worsen. We will see blood pooling in the basal cistern. So you can see all this blood pooling in these regions over here. So this is very classic for what we would see in a subarachnoid hemorrhage, as opposed to having this crescenteric or convex lens shape at the periphery. Okay, so this is very classic for a subdural hematoma, and these patients will classically not usually have focal neurologic deficits, but they will usually have meningeal signs. That's particularly high yield to remember. They will not usually have focal neurologic deficits, which makes this stand out, especially in board questions. Okay, now we're still talking about subarachnoid hemorrhage because there's a couple other high yield things I want you to be familiar with. Generally, for subarachnoid hemorrhage, when you're treating these patients, you would usually do either coiling, endovascular coiling, or microsurgical clipping. Okay, but that kind of stuff isn't really high yield for step one. What they do like to ask about for step one is the associations and the major complication of subarachnoid hemorrhage. Anytime you have any hemorrhage, the first thing you're thinking about is rebleeding. You do not want the patient rebleeding. Rebleeding is usually going to be, within the first 24 hours, give or take, especially in a board question. So if a patient has symptoms suddenly or a really bad headache less than 24 hours after a subarachnoid hemorrhage, think about the patient potentially has a rebleed. Even the rebleeds, if they're rebleeding, they may have focal neurologic deficits, potentially. Okay, so the key is you want to control the blood pressure. So keep BP controlled. You don't want the patient's blood pressure to be, 190 over 80 or something. Okay, so that's the key. So rebleeding less than 24 hours. Now, that's like medium low yield, but the reason I bring that up is because you have to compare that to cerebral vasospasm, which is very high yield. So the way this works is there are, release of vasoconstrictive factors from the damaged erythrocytes, from, the subarachnoid hemorrhage. These vasoconstrictive factors are going to kind of counteract some of the vasodilatory factors and lead to unopposed vasoconstriction. This is particularly a problem if you have these vasospasms, because you can have ischemia, right? If the vessel closes, it's kind of like Prinzmetal's angina, where the vessel is completely going to close for some period of time, and you might have ischemia to a region of the brain. And so that's the concern. Because of the subarachnoid hemorrhage, you're predisposed to this cerebral vasospasm. This is prevented by giving the patient nimodipine. This is very high yield. Now, the nimodipine is for preventative measures, so it's given almost like prophylactically to prevent the cerebral vasospasm from happening. In a way, it's primary prevention for cerebral vasospasm. And again, timeline is important. Cerebral vasospasm, 4 to 12 days after the initial subarachnoid hemorrhage, rebleeding less than 24 hours. Okay, so make sure you're good on your timeline. When the board question, when they tell you new focal neurologic deficits or really bad headache, whatever it is, right, look at the timeline. Focal neurologic deficits can be seen with cerebral vasospasm. You don't see them very often with the initial subarachnoid hemorrhage. You do see meningeal signs though. Okay, head CT, you might do a head CT because they have this bad headache. It's usually negative. Okay, so keep all of this in mind. And major associations, autosomal dominant polycystic kidney disease is a big one. Ehlers-Danlos is another big one because of the tendency to develop the Berry aneurysms. Again, going back to subarachnoid hemorrhage, because this is a very high yield topic. Now, let's just say, you have a patient that has a thunderclap 10 out of 10 headache. It seems classic for subarachnoid hemorrhage. And in the board question, they get a head CT, but let's say the head CT is negative. Then what do you do if the head CT is negative? Then the best option to pick is lumbar puncture. Okay, now if it's negative again, it's probably, especially in a board question for step 1, it's probably something else. But the lumbar puncture shows xanthochromia. What is xanthochromia? It's a yellow discoloration of the cerebrospinal fluid that is caused by the presence of bilirubin. Again, if you're bleeding into the area of the arachnoid and pia, you might see bilirubin from the red blood cell breakdown, right? And that's going to cause the xanthochromia. You could also see red blood cells in the lumbar tap. Now, if you see red blood cells in a lumbar tap, you have to be very careful about this. Okay, so you say you do an LP and you see red blood cells. Now, when you do an LP, you usually take 4 vials or tubes, right, when you do the LP. If the vials are decreasing in the amount of red blood cells, okay, so you take the first tube, you let the cerebrospinal fluid drip into the tube, right? Then you take the second tube, you let it drip in. If the red blood cells are decreasing in each tube, that tells you that you probably have a traumatic tap. Okay, that means that you might have hit like a capillary or something when you were first putting in the needle. That doesn't tell you have a subarachnoid hemorrhage. If the red blood cells are pretty constant throughout all 4 vials, that would be more consistent with subarachnoid hemorrhage. Okay, so just another little thing, little detail that they could ask you about to make sure you're familiar with.